Thanks very much, Kate, and thanks, Vivian, also for that great insight into the health economic challenges as well. So I will start by giving a introduction to PHG and also then segueing into our interests and work in pathogen genomics, which naturally does include interests in antimicrobial resistance and surveillance. Brief introduction to some of the key things that are happening in genomics and AMR policy in the UK, and then focus on some of the very well-known challenges that we're all thinking about. Why is this difficult? Why is this a hard problem? And then some insights from a policy perspective on how we can think about these difficult problems. Um, I will get the spoiler alert in early. Unfortunately, I don't have a magic wand. So I've been working in policymaking for over 10 years, and many of the issues that we're talking about remain hard problems to solve. But that doesn't mean that we shouldn't think about them, and that doesn't mean that we, shouldn't keep trying, because it's very worthwhile to do so. But I will talk about how we could think about them and also lessons that we could take from other broader areas of healthcare and genomics implementation that could help us to think about how we might want to approach some of these challenges with AMR and surveillance. So PHG, we are a health policy think tank based in Cambridge and associated with the University of Cambridge. We have a particular interest in genomics and related technologies and how they can be used for better and more personalised healthcare with a vision to make science work for health. We have been active since 1997, so we were first founded as a unit to explore the implications of the Human Genome Project for the NHS. At that time, we didn't know what the human genome could tell us, what the scope was, and there was an interest to really understand what might this mean for healthcare. So our interests cover human genomics, but also pathogen genomics and the interface between the two. We also think about personalized and precision medicine and the technologies that can help us deliver those. So we're not just talking about other omics, but also data, the data landscape, and transformative technologies like artificial intelligence, which particularly in the human genomic space, people are talking about a great deal. And to carry out our work, we're funded by philanthropy grants, and we also undertake commissions. So the primary focus of our work is to help policymakers understand how new technologies could improve healthcare and what actions need to happen in order to put these innovations into practice. So we work with a very wide range of people, including academics, clinicians, broader healthcare practitioners, clinical scientists, regulators, ethicists, the legal profession, pharmaceutical and biotech industries, big and small, other commercial companies, non-governmental organisations, charities, government departments. If I've left out the type of organisation that you work for, I do apologise. We also produce a range of outputs for different audiences, and these can vary from technical reports that answer a particular question to more wide-ranging policy discussion pieces and shorter, more accessible briefings, such as blogs or explainers. So below on this slide, I've just highlighted a few recent examples of our work. So starting from the left, this is a project led by senior policy analyst Chantal Babdevilliers on heat health and human genetics, which was a blue skies kind of scoping project looking at research into human health and particularly the heat response and what this might mean in the context of climate change, particularly how extreme heat conditions are going to become more common within, globally, and how looking at the genetics underlying the human heat response might have an impact on how we, say, plan health services or intervene. The next report was a collaboration with the Physiological Society, exploring how physiology and physiological research could play a role in the delivery of personalised prevention approaches. And we launched this report with the Physiological Society in Parliament earlier this year. The third item is a briefing that our colleague Elizabeth Redrup-Hill wrote on trusted research environments and how different ways of thinking about federating these environments might help with overcome some of the barriers with data sharing. And in it, Elizabeth outlines some of the different definitions of what federation might mean and how it could work in a more practical context, and some of the ethical and legal barriers that we need to think about in order to overcome these challenges with data sharing. And then finally, work led by Heather Turner, which looked at host genomics and lessons for infectious diseases. And in it, we determined that this is a very broad area of research where a number of recommendations were needed in terms of how we think about research into host and genomics and infectious diseases to really try and bring together how we could get the most out of this quite complex and nuanced area. And also, I think the human pathogen interface, I think, is something that we might want to discuss later on. So, what have we been doing at PHG? So, I took a bit of a trip down memory lane. And just by happy coincidence, one of the first items that I wrote and published when I started working for PHG Foundation in 2014 was a briefing note on genomics and the management of antimicrobial resistance. So it would not surprise you to know that many of the issues which I discuss in that briefing are still very pertinent and relevant today, including effective data sharing, coordinated and consistent approaches to use of genomics, challenges around resource availability, how we prioritize use of genomics, so the context in which we want to use it, which pathogens, and then communication around guidelines and standards of practice. I'm sure this is all still very relevant today. So this briefing was part of a broader program of work, which was undertaken before I joined the foundation and which was being completed when I did join. And it was a UK landscape review into pathogen genomics and how pathogen genomics could be used for the benefit of both public health, not just only the public health services, but also clinical services. And this made a number of recommendations, which were mapped onto pathways for service delivery and research and development. And then also we made recommendations for how we could catalyze the delivery of these two pathways, focusing on data analysis, configuring services, standards, validation and accreditation, coordination, development. In the interest of time, I won't go into any more details than this, only to say that many of the highlighted fundamentals remain the same. We have made progress, but I think the types of questions we're asking have changed a bit. I think the most important change that has happened is that in this report, we also made the case for sequencing. And I don't think there's anyone on this, in this seminar who would argue that we need to make the case for sequencing as a technology. We know it works. We know it's available. It's much cheaper than it used to be. There's many use cases demonstrating its value. And I think the question really now is how can we get this into practice more consistently? Other areas of work that we've done with external organizations. So these are a number of reports that we completed for FIND, who are an organization based in Geneva, who have a particular interest in bringing diagnostics and diagnostic technologies into lower resource health settings. So we carried out reviews in a number of areas, which are highlighted in the slide. I think all I want to say about the first three reports is that it just demonstrates that it's really valuable to consider the broader context in which you're thinking about the use of genomics when it comes to surveillance, because surveillance also had a very important role, we know now, in the management of the COVID-19 pandemic. It's played an important role in the management of viral hemorrhagic fevers. And just an aside, that was a fascinating project, and viral hemorrhagic fevers are very much at the top of my list of diseases I never want to encounter in my life, ever. Near patient pathogen sequencing considered how do we take sequencing out of centralized laboratories and into the environment? How can we, what initiatives and opportunities are there to bring sequencing into lower resource settings where, for example, you can't have bricks and mortar laboratories? So there's lots of really good case studies being carried out looking at how you can put small sequencing laboratories in a suitcase or in the back of a truck and drive them to where they're needed to help you carry out surveillance for your outbreaks. But the big item on antimicrobial resistance was a review we did of the international landscape into sequencing for antimicrobial resistance surveillance. And we found that there were challenges in all of the areas listed in terms of understanding, in terms of identification and sharing of best practice. But what really stood out to us was the very fragmented data landscape, in that there are lots of internationally databases available containing information about antimicrobial resistance in different pathogens, in surveillance, and there is not enough connection between them. It's difficult to standardize the data that are collected, and sharing these data is also more difficult. Fragmented surveillance efforts are also something that we saw. So while this work was carried out a couple of years ago, it does show that these challenges are lifelong and universal. And at the expense of sounding like a broken record, it does give us at least a clear way forward in terms of the vital items that I think we could think about. So what's going on at the moment? So I'd like to thank Hayley Wilson, who's a policy analyst in the science team at PhD, who's been thinking about these issues in the context of what's going on at the moment, and has really helped to gather together some of the information about what's going on, and also to help shape some of the thinking and ideas that we've been trying to develop in the past few months. So what are the opportunities in terms of policy, what's going on at the moment? So UKHSA published their pathogen genomics strategy last year, and this is quite a broad overview of what they're planning to do. And it's important to note that they're, saying the things that I think need to be said. They want to provide nationally coordinated high throughput pathogen genomic sequencing services. They're, going to undertake a genomics workforce transformation. They're going to commit to pathogen genomic data sharing. And antimicrobial resistance is one of the priority areas for for this strategy. This is a first step. What we would expect to happen soon, and I'm not sure when this will happen, is to get more information on implementation, because while this strategy has really helpful information on what they would like to do, we need more details on the how, the nuts and bolts of what would need to happen. Secondly, there is a currently open inquiry in UK Parliament into antimicrobial resistance, which is closing for evidence on the 13th of March. So I think anybody, and I think we did talk about this at the previous seminar, but if anybody thinks they have something to say about it, I think getting your message across to policymakers and to people in government who are thinking about this is important. And then finally, just to highlight, I think a couple of crossover initiatives that are linking, I guess, the clinical genomics and the pathogen genomic spaces. The first is MScape, a program which is a collaborative initiative led by UKHSA, but also is involving NHS and academic partners, including the NHS Clinical Respiratory Metagenomics Network led by Guy's and St Thomas's. And the plan is that UKHSA will take anonymous pathogen data from multiple labs that are using metagenomics for diagnosis and analyze it at a national level to monitor trends, epidemiology, and pathogen emergence at speed. Why not add AMR into that, investigation? So I think there's again, ways to think about how can we use what's going on at the moment to benefit what we want to achieve. And then finally, there is the network of excellence via the Genomic Medicine Service in pathogen sequencing, and which is looking at pathogen sequencing combined with host immunity profiling in patients with acute illnesses in healthcare settings. And again, AMR is, is a universal issue. It impacts every area of clinical care that might involve bacterial pathogens. So I think thinking about how we can bring many different areas together, particularly getting the clinical perspective, is important. So I don't need to tell this audience about why, too much detail about why this is difficult. We know pathogen genome sequencing has utility. If I had to choose the challenge, which I think it's really important to tackle first, and the issue which sort of underlies many of the challenges that we're talking about, it would be the data landscape. This is a universal healthcare challenge, and I'm sure my colleagues who've listened to me rabbiting on about this many times are probably sitting there rolling their eyes right now. But there is a real need for interoperable linked data to help us understand who has what and what is going on. The challenge being sequencing data is held in many places by different people. It was collected for different purposes. And how can, there are many opportunities to consolidate what we have rather than setting up new things. Other reasons why this is difficult, reporting of patient outcomes. And I think this really touches on what Vivian was talking about. So I'm really glad that you spoke about the economic issues, because it is clear that there is not enough information on the cost benefit of doing this. We have lots of good examples of like individual case studies, but speaking to clinicians, what they tell us is that we need to provide really detailed, cost benefit analyses to our, say, commissioners or our decision makers who understand that if you use pathogen genome sequencing to help you understand an outbreak, to prescribe the right antimicrobials, to understand what your pathogens are resistant to and susceptible to, and then say it saved us money because the patients had better outcomes, they were in hospital for less time, we saved money on the drugs bill. That could really help us to make the case for this. And those really detailed studies are not as common as they need to be. So I think that's really an area where there is an opportunity. There's also the challenge around different uses of genomics. Clinicians can need genomics for quite specific, very patient-facing uses, but obviously researchers will need genomic surveillance data to help understand, phylogenies, relationships between different pathogens, how they're spreading, whereas clinician is like, I need to know what my patient's got right now. Is it resistant? What drugs can I give them? And then finally, there's the very knotty question of what would a routine service look like? I think this is quite a challenging and interesting problem. I think we circle around it quite a bit, and we really need to get down to the details, the nitty-gritty details. What would this look like? So how can we think about these difficult problems? So in health policy, as a policy think tank, what we do is we try and put ourselves in the policy and decision makers' shoes. What do they need to know? They like to know how much things are going to cost. They like to know how quick things are. They like to know what pathogens do we want to target and why. They want to know about patients, benefits to patients and services. People who are commissioning services also really want to know about the logistical issues. What kit do I need? What people do I need? When do I need them? Do I need to train them? Do I have enough laboratory space to actually host all the shiny new kit that's needed? Does it fit into my budget? How does it link to the other budget where I've got to consider the drugs and moving patients from this ward to this ward? So these are all, rather very nuts and bolts things that you need to think about, but it really helps to think about the problems in terms that the decision makers understand. There's also, when we're carrying out this work, think about what do the regulators need to know. So if you need to get something approved by the MHRA, for example, what accreditation and validation options do you need? What type of evidence do you need to collect in order to smooth the path through the regulatory approval process? And one way we can think about these challenges is sort of thinking about translation into research and into sort of research funding. So another way that we think about difficult problems is to really highlight the things on which other things depend, and is to give people a very clear steer about what we would like them to do. So harking back to my previous comments about data, I think resolving the data landscape, just sounds like something we could do over a cup of tea, is one area where I think it would benefit not just AMR surveillance, but also healthcare more generally. try and focus on what you want people to do, how you want them to do it, and who does it, could do it if possible. So this is an example from our Pathogen Genomics into Practice report. And of course, it is outdated because Public Health England has since been superseded by UKHSA. But I think the principle holds is that if we do want to get really embedded sort of surveillance, genomic surveillance into healthcare, we need agreement between the public health body or the UKHSA or PHE, NHSE to really pin down who funds what, who delivers what, and how we can understand how we can develop services that benefit both parties. And then a second example, which was about data, and I think this will be crucial, looking ahead into the future, is in order to work out the data landscape and how we might manage it, is to really identify who's collecting the data, how we could work together to sort of standardize data collection, and then also how we can work together to share the data and to make certain data public to certain parties for reasons of public health and managing this underlying challenge, which is how can we reduce the spread of antimicrobial resistance, but also how can we understand how it's evolving and developing. So opportunities in the wider health space, harking back to my previous point about what are the things on which other things depend. The data, sorry, I'm sounding like a broken record about the data, but I just want to highlight a couple of examples from the wider health environment, which I think could provide valuable insights and lessons into how we might want to approach managing some of these challenges. So the first is the Health Data Research UK Gateway. And this is a initiative that has been set up by HDR UK, which essentially streamlines the experience for users in terms of searching, discovering, and requesting access to a large number of health and associated data sets, and not just the data sets, but also analysis scripts and software, publications and research projects. So it's essentially a front door to data. Users can register, they can look through the data sets that are listed in the gateway, and then they're given the opportunity to get in touch with the data controllers to access the data. I should point out that the gateway doesn't host any data directly, but it does provide this sort of centralized place where people can go to find out where these data sets are held. This is also backed up by a set of guidelines and standards for the data, which is listed in the gateway. And there's also the HDR UK Alliance, which is made up of a number of organisations who have worked together to develop standards in terms of how data are collected, what metadata you need, and how we can try and build some standardization and consistency across health data sets in general. And by health data sets, I don't just mean data sets on people. I mean, that includes data sets on pathogens too. The other advance is, or opportunity, is the independent review headed by Professor Kathy Sudlow into the UK health data landscape. And this was published late last year, and she made 5 key recommendations to transform the national health data ecosystem, focusing on what needs to happen and who needs to contribute. One key recommendation that she made is that we as a nation, or UK nations, need to establish a national health data service. And she highlights who she thinks should be involved in doing that. And I would argue that pathogen genomic data would be a vital part of this picture. And then hot off the press, I think yesterday, there was a report out from the National Audit Office painting a slightly not as positive it could be picture on how the UK government has been dealing with antimicrobial resistance. And having done a quick scan of this report, I didn't see any mention of pathogen genomics. So I do wonder if there was a opportunity there for, say, TARGetAMR consortium to say something about how pathogen genomics can and sequencing and genomics could help with the management of antimicrobial resistance. So I guess just some final thoughts from me before I end. Getting new technologies into practice is challenging. It's a universal healthcare issue, and I want to assure you, it's you're not alone in thinking about some of these really big ticket issues. When thinking about what you want to do, it's something that's come up in a lot of the policy making we've done over the years, is not to let perfect be the enemy of good. Sometimes we have to accept compromises in order to get to where we need to be. Speak to the issues that policymakers are worrying about in sort of terms that they understand. Take advantage of what's already going on, and don't reinvent the wheel. I know it's very tempting to go, oh, I'll set up a new thing and it will be better, but I would argue that we can take advantage of many good things that are already happening. And I will stop there.